Venom is a complex conglomeration of many substances, some of which are frankly toxic, while others serve as a vehicle, distributor, or digester. Venom is usually secreted by special epithelial cells and stored in the lumina of exocrine glands. In practically all venomous animals, it is projected into another organism by biting or stinging. Cottonmouth, the prominent white buccal mucosa, gives this genus its common name. Mature members have a dark olive color, a heavy body, and a broad head. Copperheads, the head of these snakes is solid copper to red-brown. The rest of the body is marked with dark crossed bands that resemble dumbbells. Massassauga, this shy and gentle snake of the rattlesnake species, have 9 large shields arranged in rows across the crown of its head. Pygmy rattler has a small slender body that seldom exceeds 30 inches in length and displays characteristic dorsal head scales. True rattlesnakes. Most, but not all rattlesnakes have a set of interlocking terminal horny segments known as rattles. A characteristic buzzing sound, similar to the sound of escaping steam, may occur before a strike. Elapidae, coral snakes. Coral snakes are slender snakes ranging from 2 to 4 feet with brightly colored rings circling the body, but not the head or tail. Red on yellow, kill a fellow. Red on black, good for Jack.
The snake fauna of the Philippines is related to those in Malaysia and western Indonesia. Out of more than 60 species, 7 are venomous. Probably the most important snake in the Philippines is the Philippine cobra. Cobras are the leading cause of snakebite death in the Philippines.
Patients bitten by a non-venomous snake usually can be discharged after tetanus toxoid inoculation and local wound care. If the snake cannot be identified, the patient should be observed closely for 4 to 6 hours for signs and symptoms of envenomation. Prophylactic antibiotic therapy usually is unnecessary. Persistently tender snake bite wounds may contain an embedded tooth fragment that can be detected radiographically.
Snakes are carnivores that use their venom primarily as an offensive weapon to obtain food. The potency of the venom allows the prey only several minutes to withdraw from the scene before its death. Crotalus venoms are rich in enzymes, which causes rapid spread of venom through tissue by hydrolyzing connective tissue. The facial pit contains thermal receptors that can detect changes of as little as 2 degrees Celsius 1 foot in front of the nose. Because it is highly sensitive to temperature change, the facial pit allows the snake to recognize warm-blooded foes. Pit vipers have movable fangs that rest on the roof of their mouth and rotate forward during a strike. This potentially allows intramuscular penetration. Venom glands are modified parotid glands. Contraction of voluntary muscles causes venom discharge, so that the snake controls the amount of venom injected. The venom sac contains lethal adult dose of venom. Fortunately, the snake usually does not discharge the whole sac.
King cobras produce more venom and have the largest venom sacs of any snake, yielding up to 2 teaspoons of venom. Now that may not sound like much, but it's enough to kill up to 20 adults. When injected into the body, the neurotoxic venom blocks electrical impulses passed between neurons in the nervous system. You become paralyzed, your heart and lungs shut down, and you eventually die.
Severity varies greatly between bites. The seriousness of an envenomation is determined by presenting signs, symptoms, and laboratory abnormalities. Venom affects almost every organ system with the exception of the brain, which appears resistant to direct toxic effects. Serious local dermatologic changes characterize crotalus envenomation because of the presence of enzymes. Cutaneous manifestations of envenomation are fang marks, edema, ecchymosis, vesiculation, and necrosis. Most rattlesnake envenomations cause relatively minor changes in neuromuscular transmission as compared with coral snake envenomations. The major exception is Mojave rattlesnake envenomation, which produces respiratory paralysis that may result in death. Platelet disorders, as well as microangiopathic hemolytic anemia, can develop after envenomation. Both hypofibrinogenemia and thrombocytopenia without significant coagulopathy may result from envenomation, although some venoms contain a direct cardiotoxin. Hypotension usually results from extravasation caused by intimal injury and changes in vascular resistance. The development of systemic symptoms indicates a moderate to severe envenomation. Weakness, diaphoresis, lightheadedness, and nausea commonly occur.
Numerical grading of envenomation. Minimal manifestations are confined to the bite area. Systemic symptoms and laboratory abnormalities are absent or insignificant. Moderate tissue damage extends beyond the immediate bite area. Significant systemic symptoms and signs appear along with moderate laboratory changes. Severe tissue destruction extends to the entire extremity. Serious systemic symptoms or signs are present, where significant laboratory abnormalities appear. Antidotes: Polyvalent Curtalidae Antivenin. Antivenin is a lyophilized powder of refined horse serum produced by immunization of horse with the venoms of Crotalus atrox, Crotalus adamanteus, Crotalus durissus terrificus, and Bothrop atrox. Antivenin is necessary for all significant Crotalus envenomation unless the risk significantly outweighs the benefits. The only absolute contraindication to antivenin use is the lack of signs of envenomation. A relative contraindication is horse serum sensitivity. Dosing depends on gradation of envenomation. The most serious adverse reaction to polyvalent Curtalidae antivenin is a type 1 anaphylactic reaction to horse serum, especially in patients with horse serum sensitivity. Up to 80% of patients who receive antivenin may develop serum sickness within 3 weeks. Fever, headache, myalgias, arthralgias, and urticaria characterizes this. Patients who receive more than 7 vials invariably develop serum sickness.
Antivenin neutralizes pit viper venom but does not reverse local injury.
Sensitivity testing. Sensitivity testing should not be done in patients for whom antivenin is not needed because such testing itself may sensitize patients and complicate future antivenin administration. The physician must be prepared to treat an anaphylactic reaction before administering the test. An IV line should be in place, and oxygen, epinephrine, and diphenhydramine immediately available. For patients without horse serum sensitivity, sensitivity testing is performed by intradermally injecting 0.02 ml of horse serum diluted 1:10 into one location and injecting 0.02 ml of normal saline in opposite extremity as a control. A wheal and erythema indicate a positive reaction. No reaction by 20 to 30 minutes indicate a negative reaction. For patients suspected of horse serum sensitivity, the horse serum should be diluted 1:100, 10 times weaker, and administered in the same acute care setting under direct observation. First aid. Move the victim to the medical facility as soon as possible because antivenin administration is the most important treatment. Remove all constricting items such as rings immediately. Put the victim at rest, give reassurance, and keep warm, since activity may increase the spread of venom. Likely immobilize the injured part below the heart. If possible, obtain the snake for identification, taking extreme care to avoid additional bites. The snake must not be directly handled. Do not give alcohol or drugs in the field, and do not wait to evaluate the seriousness of the envenomation, since early administration of antivenin is most effective. Tourniquets should not be removed in the emergency department until intravenous lines are established and antivenin therapy is ready. Application of a lightly constricting band above the swelling is commonly recommended to prevent lymphatic spread of venom. While a constrictive band may limit systemic spread of venom, increased local morbidity may occur and increased venom concentration at the bite site. Wound care. The affected area is cleansed with medium pressure irrigation using very dilute povidone iodine solution. The wound may be left open or gently covered with non-adherent hydrophilic dressings. For the first 3 days, the extremity should be immobilized below the heart. Give tetanus booster if the person has not been adequately immunized within 5 years. Prophylactic antibiotics are appropriate for high-risk wounds. Debridement or hemorrhagic blebs and necrotic tissue should be delayed for 3 days until hemostasis is normal.
Ay, tao yung harap ko doon. Hindi, tataas ko lang.
Taas mo.
Yeah, square na siya.